listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is July 21st, 2023, and I'm your host, Dr. J. Portnoy. Our topic today, our orientation series on diagnostic testing. Our presenters are yours truly, Dr. J. Portnoy and Dr. Aarti Pandya. And we're in the section of allergy, asthma, and immunology at Children's Mercy Hospital in Kansas City, Missouri.
All right, good morning all. Welcome to Conferences Online in Allergy. It is July 21. Today we are having our speakers Jay Portnoy and Aarti Pandya, who will be talking about diagnostic testing, and the second presentation will be on immunotherapy. All right, thank you.
Thank you, Chris. And let me just share my screen. Okay, can you see my screen now?
Yes, we can.
Great, thank you. And welcome back to Conferences Online Allergy, our orientation series. This presentation will be on diagnostic testing for allergy, so something that I think isn't covered enough, but I've taken a particular interest in, because if you don't know what you're treating, then you don't really know what to treat it with. I'm co-presenting with Dr. Pandya this morning. In an hour, we'll be talking about immunotherapy. These are our disclosures, and these are the learning objectives for this presentation. So I have a few scenarios, and I was just wondering if Dr. Pandya, if you could tell me what you recommend. We have a 9-month-old who has a positive blood test for egg allergy. She has never eaten egg. What do you tell? This is such a common thing that happens. What do you recommend your parents when this happens?
I think what commonly ends up happening is that the individual gets told that they have a food allergy and they have to avoid the food, forever, essentially. And as we'll see in this talk, we'll kind of determine what likelihood the patient is to actually have a food allergy in the context of having a quote unquote positive test, or as we also call sensitization on testing.
Yeah, it's a real challenge when somebody just does a blood test and you don't know the context and never eaten the food. How about if a 5-year-old has a negative blood test for peanut IgE, but had anaphylaxis after eating peanut butter 4 weeks ago?
Yeah, so regardless of what the testing shows at this point, the patient has a strong pre-test probability of having that clinical diagnosis. Ultimately, and I know that that's a large part of our talk today, but knowing what your pre-test probability is super important when you go to interpret these tests.
So it sounds to me like what happened when you ate the food trumps what the test result is. Is that right? Yep. 11-year-old with eczema has a highly positive skin test for peanut. He eats peanut butter every day and loves it. Do you tell him to stop eating his peanut butter?
And no, and if I can make a personal comment about this, I was actually helping a patient one time, and I did a test on myself with avocado, and I was largely positive. Of course, as an allergist, I went home that night and I had a bunch of avocado and did not have any clinical reaction. And when this scenario comes up and I'm talking to patients about it, I bring up that same personal detail.
That sounds delicious. What if you have a 9-month-old who has perennial rhinitis and a positive skin test to dust mite and ragweed? Are they allergic to dust mite and ragweed? 9-month-old?
Well, and the vignette also says perennial rhinitis, right? And then we have ragweed with sensitization. So I think these things, all of these clinical scenarios that you've brought up here in the slide really show the importance of taking, again, the pre-test probability, what's actually going on with the patient, and how to use that when you actually interpret the test.
Yeah, so tests have their limitations. We don't diagnose based on tests, diagnose based on what's going on with the patient. Let me just go down one more. These are final questions, and the reason I ask these is because there's a 4% probability of having a reaction after each one. If a 9-month-old has a 4% probability after eating peanut, or a 4-year-old or a 16-year-old, they all have the same probability of a systemic reaction, but does your recommendation change depending on how old they are?
My recommendation does not, Dr. Portnoy. I think, and the reason we are bringing this up is because oftentimes recommendations for what to do for infants and adults may differ. Some people have gotten in the practice of potentially not offering a challenge or something like that, purely based on the age of the patient. We'll explore during this talk how that doesn't need to be there when we're managing our patients.
And what I've always found interesting is that if instead of peanut, we say bee sting, the decision somehow becomes different. Okay, now you have a probability of a bee sting, so we better give you shots and all of that stuff. And whereas with peanut, we can be a little more nuanced. I think we really need to to rethink this, because it shouldn't depend on what the allergen is. I mean, the risk of exposure to the allergen might come into play, but what the allergen that's triggering the reaction should not be the determining factor. The probability of reaction instead should take priority.
And I think a lot of what happens is you have parents or patients that come in with misconceptions from what they've heard in the media. So you're dealing, of course, with the patient, but a lot of this is also going to be talking through those misconceptions too.
Precise that media, what can you do with it? Here's an example. Let's say we have 1,000 allergy patients. That would be a pretty busy week for most of us. But picture 1,000 allergy patients and suppose that 1% of them have peanut allergy. Okay, what that means, if 1% of 1,000 have peanut allergy, that means 10 of them actually have peanut allergy. Let's say that we have an allergy test and that the test is 90% sensitive and 91% specific. Those are pretty good numbers. Let's see, did I lose anybody? Oh, never mind. So if 1% have peanut allergy and the test is 90% sensitive, that means 9 of them will test positive, 1 of them will test negative. If 99% of them, on the other hand, 99% of them do not have peanut allergy, that means that 89 of them will falsely be positive, even though they don't have peanut allergy, and 901 of them will be true negatives. Okay, that's what sensitivity and specificity means. The question is, if all you know is that a patient has a positive test for peanut allergy, approximately how many patients with a positive test for peanut allergy actually have peanut allergy? What would you say, Dr. Pandya?
I'm a little biased because I've worked through this with you, but certainly, although the conception may be that answer choice A and B are correct, we will explore how C is actually the correct answer.
Right, because 90%, that sounds like this is an amazing test, and it actually is a pretty good test, but most people would say 90% because that's what it is, but it's only 10%. It's actually 8%, but 8's close to 10%. How do we get that? Well, the patient is either one of the 9 true positives or one of the 89 false positives if the patient has a positive test. So the probability that you have peanut allergy given a positive test is 9 over 9 plus 89, or 1 over 11. That's actually the positive predictive value. So it's really very low, even though the test performance characteristics are very good. The reason for that is because the prevalence of peanut allergy in this population is only 1%. It's a very low prevalence. And so these tests are very sensitive to the prevalence in the population. So again, there's this thing called sensitivity and specificity. Sensitivity is how likely the patient is to have a positive test if they're allergic. Specificity is how likely are they to have a negative test if they're not allergic. Then there's a false negative rate and a false positive rate. And so even though the 9 in 10 seems true, it's actually 1 in 10. I did not write this as a board question. I don't know if this is even on the boards, but if you see this on the boards, you should be able to get this correct. So I guess what we're talking about is allergy tests. And in this case, most tests are dichotomous. That means there's a positive test and a negative test, and then there's a cutoff. Usually the reference test is the gold standard. That's the thing that defines the condition being diagnosed. For food allergy, it would be an oral challenge. You feed the food, see what happens. That's the reference test, the gold standard. We often don't use a gold standard. Instead, we do an index test. The index test is used as a proxy for the reference test most of the time because it's less expensive, it's easier and quicker to do, it's readily available, and it may even be safer to do. It's a lot easier and quicker to do a blood test for allergy to peanut than to do an oral challenge. And this is a confusion matrix. I love the term. Confusion matrix sounds confusing, but it really is an attempt to reduce confusion between positive and negative index test given the reference test. That's what it's called. And so given these true positives, true negatives, and false positives, which are errors, you can come up with all of these different characteristics which have various meanings. Ideally, a test will give you a lot of true positives and true negatives and not very many false positives and false negatives, otherwise known as type 1 and type 2 error. So this is the frequentist approach. Unfortunately, this is kind of a lecture type of presentation, but there's two different approaches. One is the frequentist approach. Frequentist approach takes the test and looks at its performance and uses that to predict what the patient has. So if we have a 4-year-old with suspected peanut allergy and his IgE is 10.3, which is usually elevated, and we don't have a history of ingestion, that's that first patient in the scenarios, how likely is it that they will have a systemic reaction if they eat peanut? That's really the question. If somebody's eaten the food and not had a reaction, it's usually pretty simple. Most of the time we're confronted with not knowing, and then we have to figure out what to do given test results. So Bayer did this study, and they developed this confusion matrix. And as you can see, the sensitivity and specificity was 86%. Positive predictive value was 82%. That means 82% of the patients who had a positive test had peanut allergy. So you could conclude that the likelihood that this patient, who's not part of the study, will have an 82% probability of having peanut allergy, and that's not correct. Why isn't that correct? You know? Yeah, mainly because this patient's not part of the study. They're just part of the general population, which is a different group of people than the people who were in the study. So, as Dr. Pandya was mentioning, we're pretty interested in taking a pretest probability and turning it into a post-test probability. This is the so-called Bayesian approach, named after Bayes, who was a mathematician. What we want to know is how likely is it that the patient has the disease, whatever disease we're trying to diagnose. If we have no information about it, they just walk into our clinic and we don't know anything about them, our first guess is the prevalence of the disease in the population, otherwise known as the prior, or in some cases, the pretest probability. This is our initial assessment of how likely the patient is to have the disease if we know nothing else. Let's say we want to get more information. We can ask a history. Did you eat the food? What happened when you ate the food? Given that information, that may allow you to assess that the probability is either higher or lower. Let's say the patient has a positive history of a reaction, then the posterior or post-test probability goes up. It's higher. And how much higher we'll talk about later in this discussion. That may be enough to move on with the treatment. It may not be enough. We may still want more information, so we can do another test. In this case, it might be an allergy test. If the allergy test is negative, our assessment of the probability of disease goes down. If the test is positive, then the probability of having the disease goes up. And you can sequentially do independent tests one after another until you get a probability of disease that's high enough or low enough to make a decision about treatment. That's the concept behind diagnosis. So just remember, allergy tests do not make the diagnosis. Although technically, if the test is the reference test, it does, in fact, define the diagnosis. And actually, I would propose that a diagnosis is not what we need to treat the patient anyway. What we want to know is what treatment is likely to help. How do I treat this patient? I don't care what we call it. How do I treat them? What's going to make them better? And the test provides evidence that modifies either up or down the odds that a diagnosis is present. And once we have those odds, then we have to figure out what to do with them. One of my pet peeves is cutoffs. I hate cutoffs. The frequentist approach relies on cutoffs to categorize a test as either positive or negative. So for a blood test, 0.35 is usually used as the cutoff. If the peanut IgE is 0.36, it's positive. But does that really imply the same risk as an IgE of greater than 100? They're both positive. They'll both give you the same predictive values, but in fact, they're quite different from each other, and we're not taking advantage of that information. Bayesians can also use cutoffs in the form of positive and negative likelihood ratios, but I think a better approach is to determine the likelihood ratio for each value of the test. So rather than having a cutoff, use the value of the test itself as the predictor. How do we do that? Well, most of the time we're shown this sigmoid curve, which I think is misleading. It basically shows that the amount of specific IgE antibody, as it goes up, the probability of being allergic also goes up, and there's a correlation between the two. And that certainly seems intuitive and is appealing. The problem is it's absolutely wrong because it doesn't take into account the pretest probability. If somebody ate peanut and had anaphylaxis, but their IgE is 0.1, this says that the probability is very low. We would call it a false negative. And yet tests shouldn't have false positives and false negatives. They should just give you what the test gives you. So we've done a series of studies where we determine likelihood ratios, and we'll talk about what that is in just a second. But when you do these studies, you can generate what's called a receiver operating characteristics curve, ROC curve. I'm not going to go into the details of that either, but you take the sensitivity of the test and compare it to 1 minus the specificity, and you get this kind of arc pattern. And the greater the arc, the greater the area under the curve, the more effective the test is. The test performs much better. What's interesting is that the slope of this curve is the likelihood ratio at each point of specific IgE or any value of test that you're measuring. And so if you convert it back to peanut IgE and compare that to likelihood ratios, you can do a linear regression and get a formula that will tell you what the likelihood ratio is given a particular IgE for peanut. Interestingly, in the IgE, a likelihood ratio of 1 means that you're at what was normally be called the cutoff. For peanut in this study, our cutoff was 0.22, not 0.35. So if you just measured it at 0.35, you would actually not get the best performance of the test. And we did the same thing with egg, although this hasn't yet been published. We've got two different ROC curves for baked egg and unbaked egg. And you can see the likelihood ratios are much higher than 0.35 for these foods. And so 0.35 by itself would actually overestimate the number of people who are allergic to egg if you use that as a cutoff. So what is a likelihood ratio? It's a number. It goes from very low to very high. And I like kind of the heuristic that I would use is the McGee heuristic on the right-hand side. As you can see, if the likelihood ratio is 1, then the probability doesn't change based on the test. The test doesn't actually change your estimate of how likely the patient is to be allergic. If the likelihood ratio is 0.1, which is very low, then there's a 45% decrease in the probability that the patient actually has the allergy. If the likelihood ratio is 10, that's a pretty high likelihood ratio, then your probability goes up by 45%. So the test doesn't tell you how probable it is that the patient will react. Instead, it tells you how much change in estimated probability occurs as a result of the test. That's really what the test is showing you. So if we go back to our 4-year-old with IgE and a 10.3, we start with our prior belief or credence, which is the prevalence of peanut allergy in the population. In actuality, it's about 1.5%. And if you have a history of prior ingestion, it would be a lot different. But let's say we don't have a history. We have to convert that to odds. And there's a mathematical reason for it, but I'm not going to go into. But once you know what the pretest odds are, then you can update that once you have the test results. So for our patient, we have no history of reaction. Pretest odds is 1.5%, which when we convert it to odds is also 0.015. The likelihood ratio for a peanut IgE of 10.3 turns out to be 6.1. That's just something that's measured in clinical studies. And if you multiply 0.015 times 6.1, you get 0.091. If you convert it back to probabilities, then it's 8.4% probability. So the post-test probability of a reaction using the Bayesian approach is 8.4%. Versus 8.2%, 82% when you use the positive predictive value in the Bayer study. So you see how the 8.4 is actually very close to the true answer. 82% is an overestimate. So it's taking into account the pretest probability. What about components? Well, we do have peanut components. This is not the food allergy talk, we're just showing how to use it for diagnostic testing. But if you can do what's called a reflex test. If the peanut IgE is greater than 0.35, it's an arbitrary cutoff. Then you measure components. And in this case, for our patient, let's assume that the components are as shown in this slide. Okay, so for our patient, let's go back through the table again. Pretest probability was 1.5%. Pretest odds is 0.015. We multiply it by 6.1 likelihood ratio, and we get a post-test odds of 0.092. So 88.4% probability. Okay, that may or may not be enough to make a decision about how to treat the patient. But now we know that the error H2 is 5.23, and based on the Niccolo study, a different study, that has a likelihood ratio of 25, which is actually very high. So if we start with the pretest odds of 0.092 and multiply that by 25, then we get post-test odds of 2.3, which leads to a probability of almost 70%. That's a very high probability of having a reaction. So you see how getting the components allows you to get a probability that makes a very clear decision. Avoid peanut, carry epinephrine, retest at appropriate intervals, and maybe oral immunotherapy. So again, remember, post-test odds equals pretest odds times the first likelihood ratio, and then if you have more than one test, you can multiply by the second likelihood ratio, and so you can cascade them. Where do we get these likelihood ratios? I don't see those on the test reports that I order, but they can be determined in clinical trials. Here's a study looking at likelihood ratios for rhinitis. And you can even get likelihood ratios for questions. So here, patients were asked questions like, are your symptoms seasonal? If the symptoms are seasonal, then there's a 1.5, the likelihood ratio is 1.5. It increases the probability maybe 10%. It's not very helpful. If you ask the patient if they have sneezing and a runny nose, the likelihood ratio is 1.3. It doesn't really change much at all. Those are not very useful symptoms to ask about. The problem is that there are so many different conditions that can cause those that's not helpful. For strange reason, if you ask the patient if they have hay fever and they say yes, that actually is highly predictive. So we should all be asking our patients, do you have hay fever, rather than sneezing and runny nose? Obviously, we ask for all of these things, but the hay fever question is actually more helpful based on this study. And we can also do likelihood ratios for different skin tests. Here's the skin prick test on the top. And this again divides it into positive and negative likelihood ratios rather than a value for each value of the skin test result. But you can see that if a patient has a positive test for cat, they're almost 5 times more likely to be allergic to cat than to not be allergic. If their likelihood ratio is negative, they're very unlikely to be allergic to cat. So skin prick test clearly differentiates between positive and negative, actually having and not having the allergy. If you look at intracutaneous or intradermal tests, not so convincing. The grass pollen, it hardly changes at all. There's really no reason to do an intradermal test for grass pollen. For alternaria, maybe there's more of a reason. It's a fairly weak allergen, so the intradermal might be helpful for the mold. And then you can also do that for the in vitro test, as I was showing earlier for the foods. I mentioned reflex testing. I hope you're all doing it. It's done when an initial test meets a predetermined criteria. The primary test is inconclusive without the reflex or follow-up test. It's done automatically. You don't have to do anything. Can avoid unnecessary tests, reduce the cost of tests. Most labs offer this, can set them up for you on a custom basis if they don't offer it. So for example, a reflex for cat would be if it's less than 0.35, no further testing is done. If it's greater than 0.35, then it automatically measures cat components. And you can use that to get a more accurate estimate of the likelihood that the patient is cat allergic.
And if your lab doesn't have a pre-specified reflex testing, you'll have to order those individual components, for instance, for cat, FeLD1, 2, etc.
Yeah, in our lab, they won't do it there's technical reasons why they can't set up a reflex test for cat. You can set up a reflex of a value that's in a panel. And our cat's usually measured in panels. So as a result, if it's positive, I have to go back in and just type in an add-on test. That's a good point. So this study was done by Hugh Sampson et al. And there was a significant error in the results of this table. It looked at the results of the COFAR food allergy study, looked at skin test and IgE and then components and measured the performance of the test. The problem is the likelihood ratio negative is a number greater than 1, and a negative likelihood ratio is always a number less than 1. So they made a mistake in their calculations. But I went back and recalculated it based on the data in the table. This is what the real numbers look like. And as you can see, the skin test has positive skin test has a positive likelihood ratio of 3.5. Specific IgE is only 1.59. So you'd say, gosh, specific IgE is not as good as the skin prick test. But we also have these components. So if the specific IgE is greater than 0.35, we do the component. Now we add those two together. The combined likelihood ratio for ARA-H2 is actually 4.65, which is even better than the skin prick test. So by combining these, you can get a better performance characteristics than if you look at the values individually. And so the individual assessment's not as helpful as the reflex contingency assessment. So why do you do a test? You only do a test if it has a reasonable likelihood of changing or confirming the treatment decision. If the treatment's not going to change regardless of what the test shows, don't do the test. It doesn't help. So if the probability of allergic rhinitis is in the middle, it might help to do a test. If it's very low, the patient's very unlikely, maybe they just need medications or surgeries. If it's very high, you might need to do the test to see what they're allergic to, but you can then recommend allergy shots and environmental control. Remember, medications don't care if a patient has allergy or not. That's our message from Monday. So what are we trying to accomplish with these tests? Well, let's go back to our probability of disease. What we want to do is maximize wellness. So wellness goes from 0 to 100%. I guess 100% you're really well, 0% you're really sick. Some studies call this utility. I think wellness is a better description. So let's say we don't treat the patient. And the patient does not have the disease. Well, they're 100% well because they don't have the disease and they're not taking any treatment. So that's good. If you give them, if they actually have the disease, though, their wellness goes down because they have the disease. The amount that it goes down is equal to the disease burden. How much does the disease make them less well? Because you're not treating them. Let's say we do treat them. If the patient doesn't have a disease, but you're treating them for it anyway, their wellness decreases by an amount equal to the harm from the treatment. That harm could be a side effect, it could be the cost, it could be the burden of doing the treatment. There's all kinds of harms that occur from treatment. But if you don't have the disease, you're not going to benefit from it, so your wellness decreases. On the other hand, if you treat the disease and you have it, then your wellness should go up because you get benefit from the treatment. At least hopefully you get benefit from the treatment. So how do you determine how probable a disease has to be before you recommend treatment? It's called a treatment threshold. There's a place in the middle, and this shows lines, linear relationship, but if you actually measure these things, they may not be fully linear. But if you look at the treatment threshold, above that threshold, you can justify treating because the benefit will outweigh the harm. Below that threshold, you don't treat them. So here, if the disease probability is very low and you treat them, you're doing more harm than benefit. If the probability is high, you can justify treating because you're going to get more benefit than harm. So it's always a trade-off between harm and benefit. And remember, the tests for allergy identify specific IgE, which is called sensitization. It's necessary but not sufficient for an allergic response to occur. Many individuals can be exposed and not have symptoms. So that's why we're dealing with probabilities rather than absolutes. The amount of specific IgE provides evidence that can be used to determine the probability that there'll be a response to the exposure, but it's not the whole story. There's a pretest probability to take into account. Which gets to the issue of test results, and this is probably my biggest peeve. When I order a blood test for peanut, say, it comes back with values, kilounits per liter or whatever, and then it gives you a reference range. And if it's outside of the reference range, it's red and there's a little H next to it. And a lot of doctors in practice who don't really understand what this means will circle the little H's and tell the patient you're allergic to the food, or it's a positive test. I call that the red circle phenomenon. It's not always red, but it's a good metaphor. The red circle phenomenon to me means this doctor doesn't know what they're doing. Don't order a test if you don't know how to interpret the results. The problem is the tests are reported in an uninterpretable way. So at the bottom, you can see peanut IgE of 7.8. It's flagged as abnormal. Well, what do I do with that? I mean, do they have peanut allergy or not? How likely is a 7.8? How likely are they to have peanut allergy given a 7.8? It's not useful. What we really want is likelihood ratios. So for peanut IgE of 7.8, a likelihood ratio of 18.8. That's a very high likelihood ratio. If we use the McGee heuristic, we can determine how much more likely the patient is to be allergic to peanut than if they had a negative test. So if we don't know anything about it, we can multiply 18.8 times the prevalence odds and get a post-test probability. And that may be high enough to recommend avoiding it, or may not be high enough, and we might need to do a reflex test. The same thing for egg. Here, the egg is 0.45 on the left. It's flagged as abnormal. It would get a red circle for sure. But on the right side, the egg, it's milk. Milk IgE is 0.45. On the right side, the milk IgE of 0.55 is only a likelihood ratio of 1.1, which is close to 1. So it doesn't change your probability at all. I would not call that a positive test. I would say that test is equivocal and doesn't really help you at all. If you did components as a reflex, that might help, but this is elevated, so reflex test would actually automatically do the components. So you can see that if the test would report it the way that is shown on the right, that would be so much more useful. I could use that to estimate the probability that the patient has the disease. The one on the left is pretty worthless, in my opinion. How would you like to see tests reported, Dr. Pandya? Do you find them to be useful the way they are?
I think ultimately, if we did have some type of interpretation, especially with likelihood ratios that were given at the time that these abnormal results were given, or if you call this abnormal result, then it can help guide, your clinical decision with the patient. Otherwise, as you're saying, if you're just acting on a test alone, then you're not serving the patient in the best way you could.
Yeah, basically the left side is the frequentist approach. The right side is the Bayesian approach. Let's all become Bayesians. Okay, here's an example. This used to happen to me all the time. I have to say I don't get called on by extract reps very often anymore. But here's a scenario. A rep from an extract company shows up to promote their latest ragweed extract. What do you want to know about this extract? I've got a series of questions that I would like to know, but what do you usually ask such reps when you see them, Dr. Pandya?
Yeah, I don't know that I've been approached by a whole bunch of reps, to be honest with you, from extract company, but basically, with regards to the extract, you want to know, of course, the details about the actual extract, but in terms of how you use that kind of clinically, a lot of the information here is outlined on the slide in terms of, at what wheel and flare level is it likely to predict that the patient has symptoms or not? Anything with regards to sensitivity, specificity of the test, and then what was the disease prevalence at the time. And so all of those things may help kind of determine the utility of that test ultimately for the patients that you're going to do that testing with.
Yeah, I mean, we're not going into details about skin testing. Maybe we should have when we're talking about diagnostic tests, but most allergists just categorize the results as either positive or negative, or perhaps they give it a category one plus, 2+, 3+, and 4+. I've seen that very commonly done, and they have a list of criteria for what that means, but I still don't know what that means. What I want to know is how likely is a patient with a given wheal or flare likely to have symptoms when they're exposed to ragweed? How likely are they to not have symptoms? I want to know the performance characteristics of this test given each result of the test. And this is a diagnostic test, this extract. I'm assuming they're not promoting it for treatment, which they could also be doing. I want to know what is the likelihood ratio for the various values of the skin test. What is the sensitivity, specificity, positive, negative, predictive value for the test? If they don't know the Bayesian results, at the very least, they could give me the frequentist approach, because those should be available. And I want to know what the prevalence of ragweed allergy was in the population studied, because that can have a huge impact on these values. I have to say I've done this before because we used to have reps who would show up with their greatest extract, not so much anymore. And they usually look at me and their eyes glaze over and they have no idea what I'm talking about. Because most of the time, allergists just want extracts that will give you lots of positive tests, because that means you can give allergy shots, I guess. It's not really being used as a diagnostic test. It's almost being used as a way to promote allergy shots and not necessarily to diagnose the patient. And I have a big problem with it being used that way. We need to do better. So it's too complicated. It's in the morning. You're not going to do all of this math anyway. Who wants to do likelihood ratios and spreadsheets and stuff like that? But we all have electronic medical records, at least most of us do. And the EMRs can be programmed to do all of the math for us. So here's an example of how that might work. If you look at the upper left-hand corner, we've got the pretest probability, we've got the likelihood ratio, and then we've got the running odds. So let's say the prior probability is 1.4% of being allergic. We convert it into odds, it's 0.014. We also take into account where the patient's located, the United States, whether he ate the food or not. Let's say he never ate it. If you never ate the food, then the test doesn't help, so the likelihood ratio is 1. If you live in a country and you don't know what that means, then the likelihood ratio is 1. It's possible that different countries will have different prevalences, and then that could be taken into account. So the pretest probability is 0.014. That's the odds. If you do a specific IgE test and it's 10.4, which is positive, the likelihood ratio, according to the Bayer study, was 6.1. So we multiply 0.014 times 6.1 to get 0.087. Okay, well, Since we've got a positive specific IgE, we're not going to do a prick skin test or a component or an epitope or any additional testing. So our final probability is 7.9, almost 8% probable that the patient is allergic to the food if they've never eaten it but have a positive test. And that's about the same value that we got before earlier in our discussion. If you look at the right-hand side, let's say that the patient actually ate the food, and we have that information. So the prior odds, again, is 0.014. It's very low odds because the prevalence is low. But in this case, the patient ate the food and had no reaction. So the likelihood ratio is very low, 0.001. We can't really measure it, so I just put in a very low value as a placeholder. But that gives you a running odds that's close to zero because the patient is eating the food and not reacting. Their odds of being allergic to the food are close to zero. If you do an IgE and it's positive, you multiply the close to zero times 6.1, it's still close to zero. If you do the component and you multiply it by 25, now the odds become 0.02, which converts to 0.22%. That's still below the prevalence in the underlying population. So you can see that even if you have a positive skin test, positive blood test, positive component test, and you add all of those together, if the patient's eating the food and not reacting, they still have a low probability of reacting. The test does not overwhelm the pretest probability. The bottom line is you're not going to change your opinion based on the test results. Don't do the test. The patient's eating the food and not reacting, just don't do the test. If you look at the lower left corner, it's the same phenomenon, except in this case, the patient never ate the food. His IgE is elevated, his ARA-H2 is elevated. In this case, since the patient never ate the food, but he has a positive test, now the final probability is 68%. So you can see that if they ate the food and had no reaction, it's very low. If they never ate the food, now you've got a very high probability. And if the patient had eaten the food, on the right-hand side, if they ate the food and had anaphylaxis, now the running odds is up to 1.4, which is really high. Even if the skin test is negative and the components and the epitope, if everything is negative, the final probability is still relatively low. It is still relatively high. I'm sorry, I misspoke. This is a patient who ate the food, had anaphylaxis. The tests are all negative. They still have a very high final probability of being allergic. So by using the Bayesian approach, the test results can help you make a more refined decision, but they don't define the decision. The decision is defined by what happens when the patient eats the food or whatever test you're doing. So what do we really want to know? We want to know, is the patient allergic to a particular allergen? We want to know the diagnosis. The presence of IgE suggests maybe. If there are no symptoms with exposure, the answer is no. If there are symptoms with exposure, the answer is yes. For foods, we're actually asking a different question. So I don't care if they're allergic to the food. I want to know, is it safe to eat the food, the treatment? I'm not really looking for a diagnosis. I'm looking for a treatment. What management strategy is likely to be helpful? In other words, you can have a mild reaction to a food, itchy mouth, hives, pruritus, maybe even sneezing, but these are not life-threatening reactions. They don't mean that you can't eat the food. They just mean that you might be itchy if you eat the food. The food can safely be eaten, even if the patient's allergic to it. So we're not asking, are you allergic? We're asking, is it safe to eat the food? So we don't really want the diagnosis. What we want to know is how we should manage the patient. What should we tell them to do? Obviously having a name for it helps you in that discussion, but that's what we really want to know. And in reality, the safety of the food is relative. If you look at this study that looked at the prevalence of fatal food anaphylaxis in patients known to be allergic to food. The odds of actually dying from the food allergy is about 1 in a million. It's really low. It's just slightly less than being killed from lightning strike. So even though you have an anaphylactic sensitivity to a food, you're still very unlikely to die from the food. You're more likely in the United States to die from being murdered. Death due to murder is much more common than death due to food anaphylaxis. So we should be giving our patients bulletproof vests rather than EpiPens, perhaps. That's a joke. I'm not proposing that, but it certainly does derive from this information. So we've really got two diagnostic treatment scenarios. The top scenario basically take this is a neural network. This is actually the model that's probably going to be used in machine learning to help us with our electronic medical records. You train this neural network, and this neural network can then help you to make decisions that are something that you might not be able to make on your own. Now, the inputs to a neural network are called features. Features are things like age, sex, comorbidities, test results, IgE, components, epitopes, whatever information you can feed into this, it will process, and it will give you the probability of various diagnoses. So it's a way of actually categorizing the probability of different outcomes. So you'll get DX1, 2, 3, 4 different diagnoses, and there's a probability that they have these different ones. Instead of looking at that long table of differential diagnosis that I don't know what to do with, it actually lists the diagnoses in order of their probability and tells you how probable each one is, which I think would be very helpful for an electronic medical record to do, given all of the input data. The problem is each diagnosis has different treatments. They might have the same treatments, but they also may have very different treatments. And so given diagnosis 1, the treatment benefit, there's like 4 different treatments, and some of the treatments are more likely to work than others. This is evidence-based medicine, tries to predict the probability that you will respond favorably to a particular treatment, but that's for each diagnosis. So now you've got basically 16 different treatments that you have to consider with probabilities depending on the diagnosis. It becomes a mess. I'm not sure that I really like this approach because I have so many different options and I'm not sure what to do with it. I think a better approach is to skip the diagnosis and go right to the treatment, because you can program this neural network, instead of giving you 4 different diagnoses, just give you the likelihood that the treatment will work given the features. So given whatever inputs you give it, see what treatment is likely to work. There's treatment 1, 2, 3, 4, and maybe treatment 1 is what I would start with, and then treatment 2. And it doesn't really matter to me what the diagnosis is. These are the treatments I should start with. Now, keep in mind, some of the inputs include allergy inputs. So if the patient does not have allergies, then these treatments are not likely to include things like allergy shots and environmental control. Whereas if the IgEs are high, then the allergy shots might be one of these treatments. So the kind of treatments that are offered with their probability of response is in fact determined in part by what the feature results are that you feed into this model. These models can be trained. I suspect, in fact, I know that there are groups that are in the process of training models like this as we speak. And over time, we're going to start seeing more and more information like this. This is sort of like an artificial intelligence model that can be used to do clinical decision making. I think it's just fascinating, and I look forward to working with this intelligence. So ultimately, this is the future. I'm predicting the future. Computer-assisted diagnosis and treatment. I think that's where we're headed. We've all got EMRs. If you don't, you better get one. Better get one that can do computer-assisted diagnosis and treatment. There's 3 different approaches that are commonly being used. Right now, the most common one is the logistic regression model. It's a frequentist approach. It uses a linear combination of features, gives you a dichotomous output. The patient has the disease, doesn't, and how probable it is that they have it. It can be updated with new data. As you train it with more information, it becomes more accurate. It's difficult to evaluate for non-linear feature contributions, though, and you really don't get a lot. You do get a lot of insight into the outcomes. If you look at the input of the features, you can see how much each one contributes to the diagnosis, so you can get an idea of how the diagnosis is determined. It's not a black box. Logistic regression is very popular because it seems understandable. Most of the studies you read that look at diagnosis and treatment in the literature today use this logistic regression approach. It's very common. The Bayesian approach is rising in popularity. You're going to start seeing a lot more of this. Basically, you update the priors using feature likelihood ratios, and then you combine them together. I showed you how LR1 times LR2 times LR3. You can have a whole network of these things, and it's really only limited by the number of independent features and the performance of their likelihood ratios. And as you collect more data about the different features, you can update it with more of the likelihood ratios. It's, again, difficult to use it for nonlinear feature contributions, but you can get insight into it. You can see how good each feature performs in terms of promoting a particular diagnosis. So again, it could be very helpful because you can at least learn how the different features contribute to the diagnosis. The one that's the most powerful, though, and the one that is now, I mean, ChatGPT uses this, and the AI, this is artificial intelligence now. We're using neural networks, which is a nonlinear approach. Basically making no assumptions regarding input features. Any feature you can put in, it will take, as long as it's been trained to on those features. It accounts for nonlinear contributions. It's really an almost unlimited classification outcome is possible as long as you have a large training set, which our EMRs provide to us. It's hard to update it, though, with new data. You really need almost to retrain the whole model. You can incrementally train it with new data sets, but it's actually better once you have enough new data to retrain it. Requires large training sets to improve reliability. And the problem is you have no idea what's going on inside. It's a black box. So the features go in, the recommendations come out, and what happened in the middle is unknown. So you get no insight into it. And that's what's most disturbing about people who use neural networks right now, is that you really don't gain insight. So these are conclusions. I'm sorry that it's been more of a lecture. Our next presentation will be more interactive. Dr. Pandya is going to lead that. Just to point out, the level of specific IgE does not indicate the probability of disease. It indicates how much more or less likely a diagnosis is given the test results. Components and possibly epitopes measure something different than total IgE or allergen-specific IgE. Basically, they give you a differential, the same way that CBC supplements a white count, you can get the differential. So neutrophils, lymphocytes, whatever, it helps to better refine it. The purpose of a diagnosis is to call it something. It doesn't really serve much else. It may help to estimate how effective different treatments are likely to be, but what we really want to know is what treatment is likely to be effective. It can be misleading if used loosely, so we call things food allergy. What we really want to know is it safe to eat the food, not whether the patient's allergic to the food. Newer models are being developed that will lead to computer-assisted diagnosis and treatment. You're not going to need to know any of this stuff in 20 years. The computers will do it for you. They will give you the recommendations, and your job is to serve as a liaison between the computers and the patients. And I think that things will get better then. So these are just the final takeaways. Tests are used to update your pre-test probability to a post-test. Likelihood ratio is used to determine how much more or less probable a diagnosis is than you thought it was before doing the test. Reflex tests can be used when a primary test is indeterminate, and components can help determine more details about the sensitization. And with that, I'm going to stop, but I'm sorry I dominated the discussion, Dr. Pandya, but did you have any final words that you wanted to say about diagnostic testing?
No, I mean, we are looking at this with different components, and as you mentioned, a strict level for a likelihood ratio for a food or an allergen is going to differ based on so many things. So it just goes to say that, one individual level at one point, kind of like you mentioned, the dichotomy of just one test at one point in time is not going to give you the full picture. And so hopefully with this additional research we're doing with likelihood ratio, we'll get more information about individual foods, components, etc.
And please insist that your labs start reporting likelihood ratios and not just values with the flag that says high or low, because those are not useful. Anyway, thank you for your attention. We've got about 5 minutes. Are there any questions from the group before we take a break?
I'll throw out a comment or two. So for most of us, we're raised in the linear regression age, so the Bayesian is kind of a newer way, and then AI is right at our doorstep. For the AI, as it is new to many of us, and will remain that way for a short while. We do have a presenter on COLA that will be is planned. So somewhere in the next month or two, we'll have somebody that will be talking about AI and in the world of allergy.
Yeah, I sent you his name. He actually runs a program that does research on artificial intelligence and diagnostic testing. So I think it will be absolutely fascinating. Stay tuned.
Yeah, he's on the schedule. I don't recall the date off the top of my head, but that's gonna be exciting.
I'm very excited. That's great. Anything else?
So I will comment to the second comment, and then I'll be done. When I work with the fellows, I commonly will acknowledge that it's frustrating because everybody wants kind of a yes, no, binary, black, white answer on food allergies and what should we do here? Should they avoid it? Should they try a challenge at home? Should they do a challenge with us? And there's so many different variable inputs into it. And, I kind of a quick summary, the pre-test probability helps. And then you've got all these factors to get to your post-test. Unfortunately, I can't calculate most of that or hardly any of it. So that's if it's frustrating in clinic or if you hear different responses depending on the attending, it's just because it's a world of unknowns in this situation. But we're getting closer to it, solid answers.
You highlighted on an excellent point, Dr. Miller. Different individuals have different risk thresholds too. So we're not obviously taking that into account with, this discussion, but you will find your approach after you hear all of the different approaches that individuals and attendings take.
And the thing is, as the patient, I don't want what's done to me to depend on which attending I see. I want what's done for me to be the best treatment that's available. And unfortunately, right now you get a test result and then you use your gut to say, well, that seems pretty high. Maybe we should do this. It seems pretty low. We should do that. My experience of if last week I saw somebody with a certain value and they had a bad outcome, it's going to change the way I treat all of the future patients because of the availability bias. So this can do away with a lot of that by just making things more consistent. We should all have the same facts, and then we can deal with different opinions. Anyway, I'm going to stop there. Why don't we take a 3-minute break while Dr. Pandya switches to you've got the immunotherapy slides on your computer, I assume.
Yep.
So you'll be showing your screen.
Yep, no problem.